Most of you will never be in the same rooms that I'm in. I get to hear discussions that are shaping the future of autism services. The problem is, you're not in those rooms. You don't get to ask the questions, and you definitely don't get the full story. When I saw Dr. Tarbox speak, one of the leading voices in ABA therapy, I knew this was something you deserved to hear. The autistic community deserves the same insight that professionals get behind closed doors. So when I come across something interesting, I try to bring it back to you.
I would be really okay with just completely handing over all leadership of ABA treatment for autism to autistic people. If you still allow me to work in the field, thank you, I appreciate that. Number one assumption now is if a kid is stimming, they're doing it because they need it.
Right.
It's an adaptive way that they have of dealing with their environment. If a
Sure.
stim happens because the person's feeling overwhelmed, we might teach them other coping strategies too, but we are not eliminating stimming. RBT training, which is the entry-level training, right, for folks that work in ABA, is we are revamping the entire thing in a co-creation with autistic advocates and behavior analysts working together into every aspect of how ABA is implemented.
Some ABA is neurodiversity-affirming, but other ABA is really not there yet.
It takes a while for it to disseminate. The field of ABA is at a decision point right now. If we're willing to open our hearts and work with autistic people as genuine equals in collaboration, I think it's going to happen. Another way that our things are changing, prioritizing assent. And so in the old days, and still in some places, children in ABA programs, basically they just had to do what the ABA therapist said. And if they didn't, then the ABA therapist would represent the instruction over and over until the child complied. Newer forms of ABA are saying, no, it's not right. We're doing what's called assent-based practice. And that's where the child themselves has agency. And if they are indicating to us that they don't want to participate, we don't consider that problem behavior.
It's information.
Even more than that, it's self-advocacy.
Yes.
We want our clients telling us, no thank you. Maybe it's facial expression, maybe it's body language, maybe it's running away. If that human being is indicating to us, I'm not comfortable with this, good, we want to know that. And then we need to stop what we're doing and use that as information, like you said.
If you had a parent come to you and say, my child's just been diagnosed with autism, just in a general sense, the goal of ABA treatment is to do what for this child?
Build skills to help the human being access what that human being cares about in life. Now, if the client is a child, of course, what the parent wants for the child also matters.
Sure.
We're going to put all that information together, and we're going to create the most balanced program possible based on assent, based on positive reinforcement, respect for human dignity, compassion, maintain psychological safety, and then we measure client affect, which is a fancy way of saying emotional responding. Right. Are they smiling during ABA sessions? Like genuine smiling, not compliance smiling.
Appeasement smiling.
Yeah,
right.
We want to see more happy stims.
There are a lot of concerns in the community about this premise of reinforcement in general. But when we talk about the withholding of things, what are some things that are never withheld?
In the past, I think a lot of ABA providers thought, well, it's positive reinforcement, so it can't be bad to use it. If you withhold something that a human being has a human right to access that, then fundamentally that's wrong, that's unethical. Under no circumstances is it okay to tell a child they can't have their mommy. If a child wants their security blanket or their manipulatives or any of that stuff, absolutely. We are not denying that stuff anymore. It's unacceptable. Let's say the iPad at my house. My kids do not have a right to free access to the iPad all the time.
Sure.
Sorry, no.
Right.
Maybe if my kid was autistic and that was his special interest, I'd have to think about that very carefully and I have to be
Sure.
real careful about that. But if it's just a form of entertainment that they really love, they don't have a right to access that all the time.
So we're
Can they
not
have it sometimes?
restricting
Sure.
special interests.
I think that's fundamentally wrong. So you might say like, okay, this is your security blanket. Like, is it cool if we like pause this for a second and do just a teeny bit of work?
Sure.
You know, and if you're moving towards me and your face is looking like you're safe and you're taken care of, and you voluntarily put away your thing,
Sure.
and you do a little bit of work and then you grab it back, I feel okay about that.
Right.
But again, that's with the learner's assent, with their permission, and with psychological safety. It's not me saying, no, you're all done. Now we have to do work.
What other
It's gonna take a
changes
while.
do you think would be made if we embrace working with autistic people in the field?
Choosing which skills to teach. So for example, should we teach a skill just because it's delayed?
That it's expected, it's
Right.
developmentally appropriate, we
Right.
have to teach this.
Right.
Yeah.
And so when we collaborate with autistic advocates, they tell us stuff like, look, teach skills that help the autistic person get what they need and want in life.
One thing I hear a lot is that ABA has ties to gay conversion therapy. What would you say the field is doing to kind of separate itself from that and move forward?
Yeah, it's a really shameful past, and it's true. Some of the early studies on gay conversion therapy had behavior analysts as authors on those studies, including especially the Reckers and Lovaas studies, the most well-known. And Lovaas used to be one of the most revered and famous researchers in ABA. What we need to do as a field is acknowledge that and say, yes, that was part of our past, and we need to move forward. And so a variety of things have been done and are being done. One thing that was done immediately, just 2 years after the Reckers and Lovaas paper was published, 2 other papers were published in ABA journals saying, no, that's wrong. So even back then, we had voices of dissent against conversion therapy, which is good.
It is.
And
it's
also,
good.
as a field, we needed to own it even more, and we
Right.
needed to stand more strongly against that.
I've seen a lot of providers trying to move toward LGBT plus affirming practices. What does that look like in your opinion to move towards that?
Yeah, well, so the first step, we can take a page from the neurodiversity playbook. The first step is ask queer people center their voices, and how can we change ABA therapy. I'm lucky to get to learn from some folks in that area, folks like Warner Leland. They're doing amazing work in this area. Any kind of gender-related behavior, we're just not targeting that. Let's just say, for example, if an autistic boy wants to wear a dress and their parent says, I want you to work on that as a target, an ABA provider, if they're being ethical, they must say, I will not do that.
Right. Earlier, you made several statements about social justice as it relates to ABA. Can you give me a recap on what that was?
Social justice and justice for queer folks, for different racial backgrounds, for women, right? And gender-related justice, disability-related justice has to be a core component of who we are and what we do in the ABA field. And here's why. Because the whole purpose of ABA, all the way back to 1948, was the purpose of ABA is build a world that is more free from coercion. Build a more just world. That's literally the purpose of the science of behavior analysis. It is our duty to work towards alleviating those injustices. So what that can look like, practically speaking, take a look around your community. If there's socioeconomically disadvantaged areas around your clinic, are you serving families from those areas? How about the BCBAs working in your clinic? Are they mostly white and mostly more well off? Okay, that's a question we can ask. And then it's not enough to just notice it and talk about it. Then we have to actually take practical steps. So, for example, intentionally recruiting from a variety of communities. And then, of course, once we have a more diverse set of clinicians in the door, we got to keep them. So we got to provide good, culturally humble, culturally appropriate mentorship, training, supervision.